So this is a real treat for our Lown family, as we are joined by Dr. Kimmie Ng today, who is a medical oncologist at the Dana-Farber Cancer Institute and the founding director of the Young-Onset Colorectal Cancer Institute there. So it's really a treat to have someone with her clinical expertise and her research background giving us an update on colorectal cancer. So welcome, Kimmie. And her face might look familiar to you. Morning shows because she is a very strong advocate of screening for colorectal cancer. So it's really a treat to have you join us here today.
Thank you so much for having me. It's such an honor to be here, and I am excited to share with you some of the ins and outs of colorectal cancer screening and prevention. So let me share my screen. Let me just get that.
And I'll just remind everybody, if you want to type your questions into the Q&A, Dara and I will be happy to help moderate a nice discussion after Dr. Ng has given us her talk. So please share any thoughts that you have.
So can you see my screen okay?
Looks good.
Okay, great. So I'll just start off quickly with my disclosures. These are my current funding sources and conflicts of interest. And this will be the brief outline of my talk. I hope to talk for about 40 minutes, starting off with an introduction on some of the epidemiology and statistics around what a huge problem colorectal cancer is. Then I'll talk about the various screening options and strategies for individuals at average risk, and then focus a lot on primary prevention and what we can do ourselves in terms of diet and lifestyle. I will then talk a little bit about the alarming trends that we're seeing in terms of colorectal cancer happening in younger and younger people, and then end with some concluding remarks and recommendations. So to start, colorectal cancer is a huge problem. It has been for quite a while, and in 2021 is still estimated to be the third most common cause of cancer in both men and women, with nearly 150,000 new diagnoses expected this year. It is also, unfortunately, the third leading cause of cancer death. And if you combine men and women, it is actually the second leading cause of cancer death after only lung cancer, with about 50,000 deaths expected, unfortunately, this year. This is the distribution of stage when people are initially diagnosed with colorectal cancer. And this is compiled from data on diagnoses between the year 2008 and 2017, where you can see that only about 20% are diagnosed with very early stages, stage 1 or stage 2. And unfortunately, many people diagnosed with much more advanced stages of colorectal cancer, 23% stage 3, and 18% stage 4, which is typically a stage that is not curable. This is important because stage is the biggest predictor of prognosis. The earlier the stage, the better your outcome. And this is old data now from about 10 years ago, but you can see here that if you're diagnosed with stage 1 or 2 colorectal cancer when it's highly curable, your chances now with updated data are probably over 80% that you will be cured and alive still at 5 years. In contrast, if you are diagnosed with later stages like stage 3 or stage 4, the prognosis is pretty dismal, with only 5% being alive at 5 years. Consequently, it is very important that we comply with screening recommendations and be familiar with the best option that fits our individual situation. So colorectal cancer, fortunately, is a highly preventable disease. And so what is it about this disease that makes it so ideally suited for screening? One factor is that we clearly understand the sequence of events that lead from a normal colon to a colon that contains cancer. And that involves multiple steps leading from a normal inner lining to one that is hyperproliferative, to eventually form a small polyp or adenoma, which is the type of polyp that can potentially turn into a cancer. As time goes on, this becomes a larger adenoma, which has a statistically higher chance of then turning into an invasive carcinoma. And if left in the colon untreated and not removed, this eventually develops distant metastases, commonly in the liver and lungs, which then makes it highly incurable. The other factor that makes it an ideal cancer to intervene on with screening is that this whole process takes a long time, an average of 10 to 15 years, thus giving us ample opportunity to conduct a screening intervention to try to accomplish cancer prevention. If we can catch something at the polyp stage and remove it with a screening intervention, you can completely prevent the development of that colorectal cancer, as well as accomplish early detection. If a screening intervention can catch a cancer when it's still early stage 1 or 2, for example, when it's much more curable, and when it's still asymptomatic, there's a high chance that the prognosis will be better. And so with effective screening interventions, we can both decrease the incidence or number of diagnoses of colorectal cancer, as well as decrease mortality from this disease. So what are the different screening options? Fortunately, there are many, and they can be categorized into 2 categories. One is stool-based tests, and the other is direct visualization tests. So stool-based tests include FIT, which you may have heard of from your primary care doctors or your gastroenterologists, as well as Cologuard. And direct visualization tests include colonoscopy, flexible sigmoidoscopy, as well as virtual colonoscopies. So let's talk a little bit more about each of these different options. So FIT is a stool-based test that looks for occult blood in the stool. Many colon cancers and advanced polyps do bleed, and so this is an effective way of detecting those lesions. This is something that's really easy to do. It can be collected at home and then sent back to the laboratory without ever you having to leave to go to the hospital or an outpatient center. The other benefit is that it is also low in cost and convenient with very few physical risks or complications. A downside is that it does have to be done annually every year for it to be effective. And if the result is abnormal and blood is detected, you will need a follow-up colonoscopy for this approach to be effective. The Cologuard is a FIT test that's combined with another assay to look for blood markers of DNA changes that may be happening in early colon cancers. This is also very effective at detecting these lesions, and again is also convenient because it can be done at home. And one advantage over FIT is that it can actually be done only once every 3 years rather than annually. Like the FIT, there are no real physical harms or complications that can happen, but the one downside is that it is a little bit more costly than doing just FIT by itself, and not all insurance companies routinely or consistently cover this particular test. In terms of direct visualization, colonoscopy is widely considered to be the gold standard for colorectal cancer screening because it is the most effective both at prevention and early detection. The colonoscopy involves going to an outpatient center or a hospital and undergoing anesthesia and sedation so that direct visualization of the entire colon can be accomplished with a scope. Insurance does cover a screening colonoscopy, but clearly the cost is higher. And there are some very rare complications that may occur, including complications associated with anesthesia, but also some bleeding and perforation, though again, the rates are really quite low. The benefit here though is that if it's normal, you don't need another one or any other screening test for 10 years. Flexible sigmoidoscopy is similar to a colonoscopy, except that it only looks at this very left portion of the colon. And for the part of the colon that it looks at, it is equally effective as colonoscopy. The benefits here and the people whom flexible sigmoidoscopy may be a good option for are those who may not be able to tolerate anesthesia or sedation and who may not want to undergo the bowel prep that is commonly one of the main barriers to doing colonoscopies for many patients. But the downside is obviously that it doesn't look at the whole colon, and so polyps and cancers on the other side may be missed. The other thing to know about a flexible sigmoidoscopy approach is that if a large polyp is found on the left side of the colon, you will need a whole full colonoscopy and you will have to undergo that bowel prep in order to fully detect whether there are any cancers on the other side of the colon. And then finally, virtual colonoscopy is a newer technique that tries to look at the inside of the colon using a CAT scan. And this is also quite effective, although it is a newer technique that's not consistently covered by all insurance companies. There is some radiation exposure associated with it, and you still have to do the bowel prep, but there doesn't require any sedation or anesthesia in order to undergo the virtual colonoscopy. The other benefit, the other downside potentially is that it does have to be done every 5 years, so more frequently than a full colonoscopy. And if a polyp or a cancer is found on this virtual colonoscopy, a full colonoscopy is needed, which means you will then have gone 2 bowel preps. So how effective are these various options when you compare them to each other? So this bar graph looks at the different types of polyps and cancers that all of these various tests are trying to detect. One is a diminutive or small polyp, which is under 5 millimeters. Conventional polyps, indicated by the blue bars, which are 6 to 9 millimeters. Advanced polyps, which have a much higher risk of turning into cancer. They're over 10 millimeters in size. And then actual invasive colon cancers. You can see here that colonoscopy is clearly the most effective at detecting all of these lesions compared to the other types of screening methods. But if you take a look at the purple bars that look for cancer, you can see that the stool-based tests are actually quite sensitive and good at detecting colorectal cancer. Where they fall short of colonoscopy is to detect polyps. And so you can see here the rates and the sensitivity of detecting small and large polyps is really quite low for a lot of the stool-based tests. But because it is so effective at detecting cancers, FIT is actually the screening method of choice for all of Europe and the UK. So when you consider all this evidence in terms of the sensitivity of the various screening options, it is clear that colonoscopy is the only one that can really accomplish both cancer prevention and early detection. And therefore, it is the only one that can decrease incidence as well as improve mortality. Stool-based tests are predominantly for early detection only. They do not result in a decrease in colon cancer diagnoses, but only significantly reduce mortality. What is the degree of benefit and what is the degree of evidence supporting each of these in terms of its efficacy? So in terms of the FIT or the guaiac FOBT, which is another stool-based method of doing colon cancer screening, this is supported by the highest level of evidence, that of a randomized controlled clinical trial, which has shown a 30% reduction in mortality with these stool-based tests compared to no screening at all. In contrast, Cologuard, again, is not supported by clinical trial data because it's a newer test, but it is supported by modeling studies that do seem to suggest that it might be a little bit better than FIT in terms of detecting cancer, as well as being a little bit better than FIT in detecting advanced polyps. It is less cost effective though, because it is a little bit more expensive. Colonoscopy has the highest degree of benefit with a 68% decrease in mortality with this method of screening compared to other methods. This is not yet supported by the highest level of evidence, which is a randomized clinical trial, because those studies are still ongoing. They require thousands and thousands of patients, and as you can imagine, require a long time to complete. So we're still eagerly awaiting that data. But based on what we know, we do expect that this degree of benefit is likely to pan out in the clinical trials when those data come out. And even though a colonoscopy is more expensive as an individual test, it ultimately is cost effective because of just how effective it is at both prevention and early detection. Flexible sigmoidoscopy has been studied and does reduce mortality, again, by about 30%, so similar to the FIT tests, and this is supported by randomized clinical trial data. Flexible sigmoidoscopies, when combined with FIT, are even a little bit more effective, with about a 5% additional benefit in lowering mortality. And then finally, the virtual colonoscopies, again, are not supported by randomized clinical trials because they are a newer method, but their effect and benefit is estimated to be similar to colonoscopies. They are less cost effective because this scan is expensive, and then it has to be followed up with a full colonoscopy if it's abnormal. And then just to quickly mention, because some of you might have read about a blood-based test that looks for changes in the DNA of a gene called SEPT9. This is not recommended as the primary screening method, although it is FDA approved, just because the sensitivity and the ability of this blood test to detect cancer is really nowhere good enough compared to stool-based tests and visualization tests. Sorry. Sorry, I have technical difficulties here. Okay. So if you look at all the data, colonoscopy really works, and it works the best out of all the other tests as we have talked about. There have been huge public health campaigns to try to increase the rate of uptake of colonoscopy as well as just general colon cancer screening in the US population. And these public health campaigns have worked, where the uptake of colonoscopy has increased from only 20% back in 2000 all the way up to 60% in 2018. This is still far from the 100% where we need to be, but as we've ramped up colonoscopy screening, you can see how effective it has been in decreasing the rate of colon cancers over these last few years. However, the reason that these guidelines leave multiple options available for patients is that we really feel that the best screening test is the one that gets done. And so all providers really prefer that any screening be done compared to no screening at all. So everyone should talk with their primary care doctor or gastroenterologist about which test may be best for their individual situation. Now, with the importance of screening, it is important to note that unfortunately this pandemic has really impacted the number of people who have been able or willing to undergo colorectal cancer screening. Since mid-April, there has been a 90% drop in colonoscopies and biopsies compared to the same time period back in 2019. And it's estimated that 1.7 million colonoscopies had been missed because of this pandemic. The reasons include fear of patients for coming into the hospital. Many hospitals have had to cancel elective procedures. There have been shutdowns where people can't leave. And of course, unemployment leading to loss of health care and reduced access to these screening modalities. Consequently, we fear that nearly 19,000 colon cancers are going to be missed or delayed in diagnosis. And the long-term impact still remains to be determined, but it's estimated that we may be seeing an excess of 4,500 deaths because of all these delays and missed screening opportunities. So we are really encouraging our patients to not miss their colorectal cancer screening so as not to affect their outcomes later on. So with these effective screening measures, because of the barriers to uptake and because of things like the pandemic, which unexpectedly happened this year, we do need other ways to try and prevent and decrease the risk of colorectal cancer. And that's where it's so important to understand the role of diet and lifestyle in the primary prevention of this disease. Before I go through some of the data that I'll be showing you, we do need to just do a crash course in epidemiology, which will help you interpret some of the graphs and some of the numbers that I will be putting up on the screen. So relative risk refers to the probability of an event happening. And in the case of this talk, the event of interest is development of colorectal cancer. And this compares that probability in people exposed to some dietary factor compared to those who do not consume that dietary factor. So if you have a relative risk of 2.0, that means doubling the risk of colorectal cancer in those people who consume the dietary factor compared to those people who don't. A relative risk of 0.5 means that people have half the risk of developing colon cancer if they consume a particular dietary factor. Whereas a relative risk of 1 means no difference at all between people who have the factor versus those who don't. Now, it's important to remember that relative risk is different from absolute risk, and that is relevant in terms of determining how clinically significant the relative risk is. So for example, if the baseline risk of a cancer is 1 in 1,000, a relative risk of 2.0 is a doubling, but that means the risk only goes to 1 in 500, which is still only 0.2% and quite a low risk. In contrast, if your baseline risk of a cancer is 1 in 10, then a doubling is much more clinically significant in the relative risk because that brings you to 20%. So I hope that is clear. And then the other number that you may be seeing on some of these graphs that I'll be showing is the p-value. And if that p-value is less than 0.05, that means that the comparison of that dietary factor versus not consuming that dietary factor is statistically meaningful. The other type of data you'll see me present are meta-analyses, which are combinations and summaries of individual smaller studies that look at a diet and lifestyle factor in relation to the risk of developing colon cancer. In this example, these are 9 individual studies that look at blood levels of vitamin D and whether higher levels are associated with a decreased risk of developing colon cancer. These are the individual results from each of the 9 studies, also indicated by the blue squares here. And then the summary and the combination of all of these studies yields an overall relative risk that's summarized by the yellow diamond at the bottom. And because that summary relative risk is 0.67, this suggests that this combination of 9 studies looking at higher vitamin D levels suggests that there's a 30% decrease in the risk of developing colon cancer with higher vitamin D compared to lower vitamin D. So any diamond shape that occurs to the left of 1.0 means a better outcome, and any result that occurs to the right means a worse outcome. And it's an important disclaimer that all the studies that I'm presenting to you today are come from studying large groups of people, hundreds if not thousands of patients. And none of the data should be construed as direct recommendations or applicable to any one individual person. But certainly if you're considering any of these diet or lifestyle changes, many of which I think have been recommended to you already by your cardiologist, you should discuss with your physicians first. So the first prevention mechanism I will talk about is actually aspirin, which many of you may be taking already for cardiovascular health. But it turns out aspirin has the largest amount of supportive evidence and high quality data to support a protective effect against colon cancer as well. There have been studies ever since the 1980s that have shown a protective benefit in those who have been taking aspirin, particularly if they've been taking it for many years. And these data show its benefit both in preventing adenomas and polyps from happening, as well as preventing full-on cancers from happening in high-risk populations. And much of our data in support of aspirin also comes from looking at cardiovascular prevention trials, where they've been testing aspirin for cardiovascular benefit, but we also went back and looked at whether they were protective for colon cancer and found that they were. This is a summary of some of the major aspirin trials looking at prevention of recurrent polyps. And you can see that a variety of doses have been studied for a variety of different durations, but each of them found statistically significant decreased risk of colon cancer in the people who are randomized to receive aspirin as compared to no aspirin. Other studies have shown that it does seem that a higher dose may be better, but the jury is still out on what the optimal dose may be. In this cohort study of healthy female nurses, we did find that subjects reported over 14 tablets of aspirin per week had a 54% lower risk of developing colon cancer. Clearly, a high dose of aspirin is not something to just start on your own because of the risks of bleeding and peptic ulcers, but it certainly does seem like there is a dose-effect relationship where higher doses may be more effective. Similarly, a long duration of aspirin use seems to be necessary for the full protective effect. In this same cohort study of female healthy nurses, those reported using aspirin for over 20 years had the greatest protective benefit. 42% lower risk of developing colon cancer compared to those who are not taking aspirin. And then finally, the highest level of evidence that there's a benefit came in the form of randomized clinical trials, where healthy people were randomized or randomly assigned to receive aspirin versus no aspirin. And in this pooled analysis of 2 such randomized clinical trials, we found that aspirin use significantly decreased the risk of developing a colon cancer compared to people who were randomly assigned to receive no aspirin. Interestingly, consistent with our cohort studies, the benefit only seemed to emerge after 10 years of aspirin use. And then similarly, in another randomized clinical trial called the CAP2 trial of high-risk patients with Lynch syndrome, which is a hereditary condition that predisposes to developing colon cancer, use of aspirin compared to a placebo resulted in significantly lower chances of developing colon cancer, again, in this very high-risk population. You can see here that the curves overlap until you get, again, to around 10 years. So all of the randomized clinical trial data do seem to pan out that a long duration of aspirin use is necessary for the full protective effect. And so with all this evidence, aspirin made it into the United States Preventive Services Task Force recommendations back in 2016, where it is now routinely recommended for chemoprevention purposes for people between the ages of 50 to 59 years who also have a high risk of cardiovascular disease and can also benefit from aspirin prevention for that purpose as well. It is important to note that anyone older is not necessarily recommended to be on an aspirin. And that is because there has been a subsequent trial called the Aspirin trial that randomized healthy elderly individuals over the age of 70 to receive aspirin or placebo. And surprisingly, in this elderly group of patients, aspirin actually increased death from cancer, including from colorectal cancer. So there's something different about the way aspirin works in older individuals, or perhaps in these older individuals who may have more comorbidities that do not necessarily benefit from the protective effect. So anyone older should discuss with their physicians before starting an aspirin for colorectal cancer prevention. So switching gears to what diet and lifestyle factors may be effective in helping us to decrease our risk of developing colon cancer, there has been a long interest in the role of diet in cancer development for well over a century. And when I actually typed in diet and cancer in the PubMed database this morning, there were over 53,000 research papers talking about the role and the link between diet and cancer in the database. The colon cancer is probably the cancer with the strongest link to diet and lifestyle because everything that we consume in our diet comes in direct contact with the inside of our colon. So it makes sense that it would have a big impact. This is supported by early geographic studies that actually looked at the incidence of colon cancer in different countries around the world. And very interestingly, it is found that the highest incidence of colon cancer is occurring in westernized countries, where the US has a 40-fold higher rate of colon cancer compared to Africa, for example. Clearly, the diet and lifestyles are very different between these types of countries, and that certainly suggests that diet and lifestyle has a big role. Similarly, immigration studies that follow people who move from a low prevalence area to a high prevalence area show that these people quickly assume the incidence of the high prevalence area within one generation of moving to that country. Again, suggesting that environmental influences are quite powerful. The problem is that many of these epidemiologic studies looking at diet and cancer report conflicting results, and many are not done very well. And so I like this cartoon here because it's really true. You know, one week you can read a paper about calcium that suggests it's beneficial, and the next week another paper will come out that says it's harmful. So it's very hard for patients to know what to do. So a lot of our work here at Dana-Farber has been trying to conduct rigorous studies of diet and lifestyle factors so that we can provide patients with evidence-based recommendations for what to do. So the American Institute of Cancer Research did an in-depth review of all of the studies that have been done looking at various diet and lifestyle factors and their role in reducing the risk of colorectal cancer. And when they've compiled all the evidence, they found several that have convincing data in support of a link. One, for physical activity decreasing the risk of developing colon cancer. And then these factors increasing the risk, including higher intake of processed meat, drinking alcohol, body fatness, and then an interesting one, adult attained height. It's probably not height itself, but height is probably a surrogate for some yet unknown factor that is increasing the risk of colon cancer. So let's talk about each of these a little bit more and the mechanisms by which they may be important for colorectal cancer, either harm or protection. So in this meta-analysis of multiple studies looking at various degrees of red meat and processed meat intake and risk of subsequent colorectal cancer, you can see that the summary of all of these studies show that there's a 12% increased risk with every 100 grams of red meat consumed per day in these healthy individuals. You can see here a photograph of how much 100 grams is. It's actually not a lot, but there's a significant increased risk the more that you consume. The reasons relating to why red meat may be harmful mainly involve cooking red meat at high temperatures, which produces a variety of carcinogens that have been shown to be carcinogenic in laboratory studies. including heterocyclic amines and N-nitrosyl compounds, all of which can lead to cancer, again, in the laboratory in cell lines and animal models. The other reason that red meat may be detrimental is the higher fat content in this kind of meat compared to other sources of meat. And certainly higher fat content has also been associated with an increased risk of a variety of different cancers. Alcohol is the next factor that was looked at. And you can see here that the more alcohol one drinks, the higher the risk of developing colon cancer. So consumption of 30 grams per day is equivalent to 2 alcoholic drinks per day, results in an association that leads to a 15% increase in the risk of developing colon cancer. You can see here that if someone is reporting 4 alcoholic drinks per day, that risk goes up to 60%, which is very significant. The possible mechanisms are that alcohol contains a variety of substances that, again, have been shown to be carcinogenic in the laboratory, including acetaldehyde, reactive oxygen species. Alcohol has components that may make other carcinogens more likely to induce cancer, and it may also interfere with hormone metabolism and DNA repair, which may lead to a higher susceptibility for developing colon cancer. Physical activity, out of all the diet and lifestyle factors that we've looked at, and we've looked at many, probably has the strongest protective effect. In all these meta-analyses conducted from 1988 all the way up to 2014, you can see here that all the relative risks are below 1.0, meaning a protective benefit. A relative risk of 0.80, when you look at all these studies in combination, means a 20% decrease in colorectal cancer with the more that you exercise. And in general, the amount that we recommend is anywhere from 30 to 60 minutes of brisk walking for 5 to 7 days per week. So it's not a huge amount, and even smaller amounts may be associated with a protective effect. The possible mechanisms as to why exercise is so helpful are many, but include reducing body fatness, reducing insulin resistance. Insulin can promote the growth of colon cancer in the laboratory. Physical activity reduces inflammation, and exercising can stimulate the transit time of contents through your colon. So if there is something carcinogenic in there, there's less contact time with the inside of your colon. That's another potential hypothesis. And then finally, body mass index and being overweight and obese does seem to have a link to an increased risk of developing colon cancer as well. Many studies have been done, as you can see here, which do suggest about a 5% increase in the risk of developing colon cancer with every 5 kilogram per meter squared increase in a person's body mass index. The definition of being overweight is a BMI above 25. And you can see here that among overweight individuals, there's an 8% higher risk compared to a normal weight individual. When you get to a BMI above 30, which is the definition of obese, that risk goes up significantly to 34%. The possible mechanisms here are still not exactly known, but hypotheses include, again, increased insulin levels, as well as increased inflammation in the body that happens when someone is obese. So we've talked about all these factors individually, but what is the protective impact when they're all combined? So there was a study that looked at 48,000 healthy male health professionals who were in the Middle Ages, and they looked at the adherence to 5 healthy behaviors, including eating 2 or less servings of red meat per week, exercising at least 5 hours of brisk walking per week, consuming only 1 or fewer alcoholic drinks per day, not smoking, and then taking a multivitamin containing folate, which has also been shown in some studies to be protective. Out of these 48,000 people, this study found that only 3% of all of these men followed all 5 of these healthy behaviors. But in that 3% who did, their risk of colon cancer was 71% less than those who did not follow all 5 of these. So clearly, diet and lifestyle, when combined together with all these healthy behaviors, can have a huge impact in protecting an individual from developing this lethal disease. And with all this data that diet and lifestyle and environmental influences are so strongly linked to colon cancer, these are thought to be also why colon cancer is happening more and more in young people. So here are the trends that we are so concerned about. As you can see, in people who are getting screened who are over the age of 50, the rate of colon cancer has been declining steadily. This is a huge success of screening, as we've already gone over. But in young people under the age of 50 who are not getting screened, unfortunately, there's been a steady rise in the development of colon cancer starting in the 1990s at about 2% per year in both men and women. This is something that's happening all around the country as well. And the steepest rises have been in non-Hispanic whites. Out of 47 states with available data on colon cancer incidence, this alarming trend has been seen in 40 out of the 47 states. It is also a global phenomenon where the same trends and increases in young people are seen in most countries in Western Europe, mixed trends in Middle Europe. It's being seen in Australia and New Zealand, and very interestingly, not as much seen in Mediterranean countries or the Far East, where clearly diet and lifestyle is quite different than in the US and other higher socioeconomic status countries. This is also a phenomenon that's not isolated in time, where if these trends continue and these increases continue, it is expected that nearly a quarter of all rectal cancer diagnoses will be happening in people under the age of 50 by the year 2030. And the most frightening thing about this is that we really do not know at all what the underlying causes of colorectal cancer happening in these young individuals. 16% only are diagnosed with a hereditary syndrome that accounts for why they got the colorectal cancer. And maybe another 28% have a family history of someone with a colon cancer or a polyp, but no hereditary syndrome. This means that the vast majority of these young patients who we're seeing and treating here are diagnosed for no known reason and have no known risk factors for developing this cancer. We've looked at some of the risk factors that have been increasing steadily over time and that have been associated with colon cancer overall, including obesity, as well as sedentary behavior. And we have published a couple papers that show that these factors do seem to increase the risk of developing colon cancer at a young age. But I can tell you, after seeing hundreds of young patients with colon cancer, the vast majority are normal weight. Many are triathletes and marathon runners, and they follow healthy diets. And the perfect example of the typical young onset patient that we've been seeing is Chadwick Boseman, the actor from Black Panther, who unfortunately died of metastatic young onset colon cancer in his early 40s last year. So clearly, more research needs to be done to better understand what exactly the underlying causes are, so we know who to target for earlier screening. Our most likely hypothesis is that it might be the microbiome, which is the trillions of organisms living in all of our guts right now that may be influencing the risk of developing this cancer earlier and earlier. We know that diet and lifestyle, which is so strongly linked to colon cancer, also closely shapes the microbiome, and certainly can be acting through the microbiome to be increasing the risk of this cancer in young people. And the microbiome and diet can lead to changes in our immune systems, which can also impact the ability of our immune systems to fight off cancer. So not only is the rate of colon cancer increasing in young people, but unfortunately death from this disease is also increasing in these young patients. Again, in people over the age of 50, because of the successes of screening, mortality is decreasing. But in those under the age of 50, the rates of death from colon cancer in young people is steadily rising since the 2000s. Part of the reason is that cancer is simply not on the radar of many of our young patients who are otherwise young and healthy. In this survey of about 1,000 young patients with colon cancer, 41% reported waiting over 6 months before seeking medical attention for their symptoms. Similarly, cancer is not on the radar of providers who are seeing these young people when they finally do present with symptoms, with 67% of these patients having to see 2 or more physicians before arriving at the correct diagnosis. And this means, unfortunately, that over 70% are diagnosed with advanced stages of disease, stage 3 or 4, which is much less curable and may be contributing to why we're seeing more deaths from this disease in this population. Because of all this data, the screening age has actually been lowered now from 50, which is what we've all traditionally been told to do, down to age 45. And this was first recommended by the American Cancer Society back in 2018, but now has also been recommended by the US Preventive Services Task Force in draft form, yet to be finalized, but hopefully soon. This is important because insurance companies are obligated to cover screening that's recommended by this organization. So once this recommendation is finalized, hopefully access will be available to many more young patients in the future. And then finally, it's difficult to get cancer no matter what age you are, but we do know that young people face unique challenges, with 80% of them having young kids when they're diagnosed with metastatic disease. Disruptions in schooling and career are occurring, and impacts on fertility as well as psychosocial factors. And so to try and address all of this, as well as rally a research effort to figure out why this is happening, we have launched a Young-Onset Colorectal Cancer Center here at Dana-Farber, and it's still one of the only centers in the world right now dedicated to this group of patients and this medical mystery. We have a threefold mission to provide excellent clinical care to all young patients, to raise education and awareness, and of course, to do the research to find out what the underlying causes are. Our research project is called the Beyond CRC Project, where we are trying to better understand what the risk factors are and then use that information to develop prevention, early detection, and better treatments. And basically, we're enrolling every young patient that's seen here at our center who's diagnosed under the age of 50. And we're collecting tumors, DNA, blood samples, clinical data, stool specimens for study of the microbiome, and diet and lifestyle information, so we can really put it all together to better understand what is happening in these young people. And then finally, because of issues of accessing Dana-Farber during the pandemic, and also the importance of increasing diversity in our research, we are trying to expand this project beyond just the walls of Dana-Farber by using a social media platform called Count Me In. This is a nonprofit organization that's co-sponsored by the Emerson Collective, the Biden Cancer Initiative, as well as the Broad Institute, along with us here at Dana-Farber, to directly partner with patients for accelerating cancer research. So when this project launches in March this year, we will hopefully be able to accrue rapidly patients with colorectal cancer, collect their specimens and information, regardless of the pandemic, and hopefully arrive at some answers sooner than we would otherwise. And so with that, just some concluding remarks and take-home points. One, get screened. Starting at age 45, if insurance doesn't cover it, definitely by age 50. This is the most effective way at preventing colon cancer and accomplishing early detection. And then other things that patients can do themselves in terms of diet and lifestyle are recommended by the American Institute of Cancer Research here, and include maintaining a healthy body weight, maintaining physical activity, eating a diet rich in whole grains, vegetables, fruits, and limiting consumption of things like red meat, fast foods, sugar, foods high in sugar and sugar-sweetened drinks, limiting alcohol, and then not necessarily jumping to a bunch of supplements for cancer prevention, because much of the data is not there yet and many can be harmful. So talking to your physician first, and of course, not smoking or chewing tobacco. And with that, I'd just like to quickly acknowledge all of my collaborators who've helped with all of this research at various institutions, our patients who are so passionate in collaborating with us to help find answers and advance the field of knowledge, and also my funding sources. So thank you for your time. I'm happy to take any questions.
Well, that was wonderful. Thank you. What a whirlwind of information. So, so many things for us to really jump in and dissect a little more. Thank you, Kimmie. I think probably if we just step back maybe and go back to your initial concept of prevention versus early detection, because I think that was such a simple way that you put it. And I have to say, I've not thought about it in those terms, that the benefit of the colonoscopy is really prevention, in that the polyp is really, in many cases, right, what goes on to progress to a cancer. So now that we've heard all this information, do you maybe want to just tell us again that the recommendations regarding the colonoscopy?
Yes, and I have to, present a caveat here that I'm coming at this from the perspective of an oncologist, right, who wants to do everything possible to prevent the cancer from developing in the first place. I think that gastroenterologists and primary care physicians may have a different perspective on this, but if the goal is optimal cancer prevention as well as early detection, colonoscopy is definitely the recommended first screening exam. The problem with it is that there are just so many people who are, not comfortable doing it or are unable to do it. And there are potential complications and medical reasons why someone may not be able to do it, as well as cost and insurance issues. So that's why the societies do give a variety of different options. But if the goal is prevention and early detection, then colonoscopy is the gold standard.
And I think, for a lot of our cardiac patients that we have on blood thinners, we're using a lot of platelet medications, not only aspirin, but Plavix and Brilinta, as well as full anticoagulation in cases of atrial fibrillation. When patients are on blood thinners, then the likelihood of those polyps bleeding and bleeding significantly it's even a higher risk, right? So certainly for those patients that bleeding risk, we like to do the colonoscopy so that we really quantify their overall risk. There's a couple of, and actually, maybe I'll have you stop screen sharing so that way we won't distract everyone. But there's a couple of questions that are really asking for clarification on who's at high risk, which family members are high risk, and how, in best case scenario, we should really approach screening. What are your thoughts on this?
Yeah, it's such an important question. And, it's important to clarify that all of the screening recommendations that I've talked about only apply to people at average risk who don't have high risk factors and who are not having symptoms. So they're asymptomatic. But, for people who are having symptoms, colonoscopy is the best method to find out whether or not it's cancer that's causing those symptoms. And then some of the high risk factors are people who have a history of polyps, where, again, colonoscopy is the best way to look for new polyps or cancer. And those with a family history of somebody, particularly a first-degree relative, who have a history of advanced polyps or cancer, those family members, even in the absence of a hereditary syndrome, are at higher risk of developing colon cancer. So, for example, in all the first-degree relatives of my patients with colon cancer, we recommend colonoscopies only as the best way to do screening in those high-risk populations. Other high-risk populations include people with inflammatory bowel disease, so Crohn's, ulcerative colitis, they're at higher risk as well. And then some guidelines actually consider race and ethnicity. So African Americans are known to have a higher risk of developing colon cancer at an earlier age, as well as a higher chance of death from colon cancer. And so many societies recommend starting screening earlier for those individuals as well.
And then the timing of the repeat colonoscopy is going to be dependent on what's found, right?
Exactly. So again, in an average risk individual who's asymptomatic, every 10 years after a normal colonoscopy is fine. But if you have a history of previous polyps and more polyps are found, that interval will decrease to every 3 years or every 5 years. And it's really dependent on the individual situation and the risk factors that are present.
That's such a nice overview. Dara and Brian, do you want to jump in with questions, or I'm happy to just keep?
Yeah, I'd just love to make a comment. Thank you so much. What a great overview, and speaking to a lay audience as well as professionals and physicians, and it's hard to cover everybody and everything. The one comment I would love to make is, when we talk about chronic disease prevention, which includes cancer and heart disease, there's so much commonality in this concept of being very consistent with lifestyle and the importance of that. And I think there's so much we can do better with screening, and then there's a lot of options with screening, but each individual, especially as the new year, and it's a time to make a new year resolution, think about all of those little simple things that we just heard about, you know, consistency with exercise, nutritional things that cause inflammation. And inflammation seems to be the common pathway to vascular disease and to cancer propagation and occurrence. So really just wanted to make that little point, because people may be asking why we're having a cancer screening and a cancer talk in a cardiac practice, but we really are colleagues, and we both look at this from a preventive standpoint. So thank you, congratulations, and it was a delight to hear you speak.
Thank you. It's a really important point, and it's not just for colon cancer, it's for a variety of other cancers where these diet and lifestyle factors may be helpful as well, you know, especially breast cancer, which is the most common cancer in women. So it's a very important point that you just made. These diet and lifestyle factors are primary prevention for a variety of different cancers.
And I'll just restate what we've said before. You know, over the last 10 years, as we've looked at the American Heart Association's plan to decrease cardiac risk factors, we've also seen a decline in cancer, as well as a decrease in the decline in cognitive function. So for your overall health and well-being, making lifestyle changes to focus on a Mediterranean-based diet and to exercise regularly are really good for all of us. So,
and that's a great, yeah, that's a great point as well. Those decreasing incidence curves that I showed of colorectal cancer, part of it is due to improvement in diet and lifestyle factors as well as screening. So I agree with you, that has definitely made an impact as well.
And some of our audience have heard through some of the talks over the year about the microbiome and the importance of how certain foods affect the way we metabolize and are pro-inflammatory. So it would encourage some of our audience to look at some of the previous nutritional programs that we've had. This is such an important issue. And you'll hear more about the microbiome as medical science starts looking at the importance of nutrition and integrative care.
And there's probably some overlap with the vitamin D story and inflammation as well, right? Any pearls there?
Yeah, so vitamin D has a lot of anti-inflammatory properties. It can activate the immune system. It can affect, you know, the rates at which cells grow. There are many different pathways implicated where vitamin D may be helpful. You know, unfortunately for primary prevention, it hasn't really panned out yet. There have been large trials looking at healthy people who are randomly assigned to vitamin D versus placebo, and there was no protective benefit. But there does seem to be a protective benefit on mortality after you've been diagnosed with colon cancer. So it may be more helpful after a cancer has already formed versus in healthy people who have not had cancer yet. So we're conducting some randomized trials on vitamin D for treatment of colon cancer, but right now there isn't a defined role for vitamin D for prevention.
A lot of questions are coming up in the chat about age of screening and at both ends of the spectrum. So could you comment on how early does it make sense to screen someone who is at a particularly high risk? And at what age do we stop screening?
Yeah, so for people who have high risk factors, it really depends on the individual situation. So if a patient of mine gets colon cancer at age 40, we recommend their first degree relatives start screening with colonoscopies at age 30. So 10 years younger than the age at which that cancer or that advanced polyp developed in their family member. For people from, you know, races that are higher risk, starting at age 40 is recommended. For all others at average risk, I think the new guidelines will be to say start at age 45. In terms of when to stop, there is no, you know, direct guidance there. There are different recommendations from the different societies. But in general, studies have shown that screening through age 75 is recommended. And after that, it's really an individualized discussion with the doctor about the risk versus benefits. If someone is over 75 but has a 10-year life expectancy, they may still benefit from colon cancer screening.
It makes sense because, of course, as we get older, our risk goes up. So why would we stop unless it's just that we're too old to tolerate the procedure or tolerate the subsequent surgery if we were to find something, right?
Exactly, exactly.
Okay. I have another question from the chat. Are people with IBS, so inflammatory bowel or irritable, well, I think they probably mean inflammatory bowel, at higher risk? And are probiotics a tool for prevention?
Those are great questions. So inflammatory bowel disease is a definite risk factor for colon cancer. So inflammatory bowel disease includes Crohn's disease as well as ulcerative colitis. Irritable bowel syndrome, or IBS, is not known to be a risk factor for developing colon cancer. I will have to say a lot of our young patients who are developing colon cancer get misdiagnosed with IBS initially, and that can lead to a delay in diagnosis. So IBS is really a diagnosis of exclusion. You know, I think that symptoms need to be worked up before jumping to the diagnosis of IBS. But IBS on its own is not necessarily a risk factor. And then probiotics, you know, we are starting to recommend that patients not take probiotics because we don't know what a healthy microbiome is yet for protection of colon cancer. And it might be that the organisms and communities that are in a probiotic may not be the ones that are helpful, and it may cause harm in the end. So until there's more data, we are not routinely recommending probiotics.
Okay.
So as our time is nearing to an end, maybe we should just reiterate again the umbrella recommendations that you have for all of us regarding diet and lifestyle.
Yeah, so one, definitely get screened, right? I can't emphasize that enough. And I do think that primary care physicians should start the discussion earlier because it often takes a little while for patients to end up scheduling their colonoscopy. But in terms of diet and lifestyle, I think it's many of the same factors that you are telling your patients: maintaining a healthy weight, exercising, probably at least 30 minutes of brisk walking at least 5 times a week, and then a diet that's higher in fruits and vegetables and natural plant-based protein sources as opposed to red meat, and minimizing consumption of the red meat as well as processed foods and foods high in sugar. And then don't drink or smoke.
Wonderful. And then I think a lot of our cardiac patients end up on aspirin anyway, and there might be some protective effect from that, which I think is good news.
Absolutely.
And again, we're not really starting it for colon cancer prevention alone, but if you're in a high-risk group, it might benefit you.
Exactly.
And I think it's worth mentioning that the studies that you pointed out where starting an aspirin in someone over the age of 75, I believe it was, can be harmful, did not look at people who had been on aspirin for many years, right?
So that's a really important point. They did actually look at people who were already previously on an aspirin, and there was no harm in those people. So correct, it's only with newly starting an aspirin when you're older that needs to be really discussed.
Do we have time
That's
for
great.
one quick one, which is that someone's asking about the prep for colonoscopies, and this is probably what keeps many people from having the procedure in the first place. It's so unpleasant. Any hope for the future that this is going to get any less unpleasant?
Yes, there is. I believe there are tablet forms of a prep that are being investigated and studied to see what works, and they've been more and more tolerable lately. You know, some just use Miralax, and so it really isn't that bad. And I think that the more education is out there about how to get through a prep and tips and tricks, the more that people will be willing to do it and less afraid to do it.
Good.
Wonderful. Well, this was so fun. Thank you for sharing so much data with us. I think that was just really information that I think benefits all of us and gives us things to help with family discussions, which is, I think, somewhere that, you know, we can help spread the word regarding the importance of screening with colonoscopy by discussing this, you know, with our friends and family members and making it acceptable. So thank you for all this great information, and thank you everyone for logging on and joining us today. So thank you, Kimmie, and we'll see everyone back in a couple of weeks.
Thank you.